So I think it's about time to say hello to everybody. My name is Dr. Elena Armeni, and I am one of the EMAS board members, the treasurer, and also very pleased to greet all of you today in the first webinar organized by EMAS for the year 2026. I am very honored to have with me my excellent colleagues from the board, Professor Tamer Erel and Professor Ludwig Kiesel. We will look into various aspects of endometriosis, postmenopausal endometriosis, and postmenopausal chronic pelvic pain together. This webinar, as a reminder, is free of charge for all of you who want to learn more about postmenopausal endometriosis and chronic pelvic pain. And I am aware about the fact that you are likely to have certain questions. That is what the Q&A part of your screen is for, whilst the chat is serving for various types of communication, like perhaps greeting each other or asking technical questions. We have great support from the digital team of the European Menopause and Andropause Society. And without further ado, I want to introduce Professor Tamer Erel, who has been a member of the Department of Obstetrics and Gynecology at Istanbul University, Serapasha Faculty of Medicine since 1991. His main areas of interest include reproductive endocrinology and menopause, assisted reproductive techniques, endoscopic surgery, and laser treatments for genital diseases. He actively contributed to the establishment of the Turkish Menopause and Osteoporosis Society in 1992 and has since played a key role in organizing numerous national and international menopause congresses. Professor Erel served as president of the Turkish Menopause and Osteoporosis Society from 2012 to 2015, as general secretary from 2015 to 2018, and has been a board member since 2018 of the same society. Professor Erel is currently the vice president of EMAS, and we will have the honor to listen and learn about postmenopausal endometriosis from him today. Tamer, the screen is yours.
I hope I managed, Eleni. Thank you for your nice presentation. Do you see the slides? Okay. Oops. Postmenopausal endometriosis is a very controversial topic. The lack of sufficient scientific data on this subject further complicates the matters. And we know endometriosis in its gynecological manifestations. However, endometriosis is a disease associated with many different manifestations in different organs and tissues. Oops, sorry.
Dear Professor,
okay.
Yeah, it's working.
Okay, this is my conflict of interest. First, endometriosis is defined as the presence of endometrial tissue outside the uterine cavity, but its three distinct features are important. It is a chronic inflammatory disease, it is estrogen dependent, and progesterone resistant disorder. And it affects 5 to 10% of female population within the reproductive age, and its incidence are different in women having different complaints. It may be found 2 to 5% among the postmenopausal women. There is a delay of 6 to 7 years between the first onset of symptoms and the confirmed diagnosis of endometriosis. Therefore, most cases is diagnosed during the menopausal transition period. Unifying theory regarding the origin of endometriosis has remained elusive. The theories are retrograde menstruation and implantation, sodomic metaplasia, induction of Mullerian wrist, lymphatic or homogeneous spread of the endometrial cell. Retrograde menstruation and implantation theory is the best fit one in order to explain more than 90% of the endometriosis cases. And also we know that hereditary and acquired genetic, epigenetic, environmental factors may play an important role in the pathogenesis of endometriosis. But not all, in most women, endometriosis improves after the menopause. We know that. Pre-existing endometriotic lesions may be activated as a consequence of exposure to exogen or endogen estrogens, or de novo endometriosis can occur, as it was reported in non-MHD users. According to a recent, the most important problem with the woman with history of endometriosis, there is an increased risk of early menopause. According to a recent study from nearly 300,000 women in 5 cohort studies, showed that a woman with endometriosis had a 7-fold increased risk of undergoing surgical menopause rather than natural menopause, and were more likely to experience premature or early menopause, both surgically and naturally. The older study, the Nurses' Health Study, reported a 50% increased risk of early natural menopause, defined as menopause occurring before the age of 45. The Japan Nurses' Health Study also demonstrated a 3.4-fold increased risk of early menopause in endometriosis patients with infertility compared to fertile groups. Endometriosis, particularly ovarian endometrioma, can lead to early menopause as well, even in women who have not undergone surgery. Endometrioma can cause detrimental effects on ovarian tissue by producing excessive amounts of reactive oxygen species, cytokines, disrupting ovarian angiogenesis, inducing apoptosis and fibrosis. Not only bilateral salpingo oophorectomy, but also conservative ovarian surgeries such as cystectomy can lead to ovarian failure. Laparoscopic cystectomy has been shown to decrease the antral follicle count, serum anti-Mullerian hormone, while increasing the serum FSH concentrations. And in a retrospective study, women previously submitted to bilateral cystectomy were found to be younger at menopause than those with unilateral endometrioma. Endometriosis negatively impacts multiple aspects of health-related quality of life. According to a recent Australian longitudinal study on women's health, endometriosis was found to be associated with worse physical, mental, and social functioning and well-being, and bodily pain was the most affected health-related quality of life domain. And endometriosis has a negative impact on female sexual function. Women with, in this review, the woman's sexual function was assessed by female sexual function index, and women with untreated endometriosis displayed altered sexual function, as evidence lower scores in all FSFI domains. Moreover, a recent French online survey has also claimed that menopause was associated with decline FSFI scores among women with endometriosis, with arousal being the most affected domain. When a clinician who gives health care to postmenopausal women encounters a woman with a history of endometriosis in the clinic, one should be aware of the health problems that may be associated with endometriosis. Moreover, these endometriosis-associated health problems may also be affected additionally by menopause. And endometriosis-associated diseases have common etiologic mechanisms such as the same genetic mutations, similar immune behaviors, or exposure to common environmental toxications. And the drugs which we are using to treat the endometriosis can also have a detrimental effects on osteoporosis and mental health. Bone health is estrogen dependent. Women with a history of endometriosis at particular risk of the long-term adverse effects estrogen deficiency as a consequence of repeated course of gonadotropin-releasing hormone analogs, progestogens, and of course, surgical menopause itself can cause early menopause. And early menopause is a risk factor for, early menopause can be a risk factor for osteoporosis. Chronic inflammation increases the risk of cardiovascular disease in women with endometriosis. There is a higher risk of hypercholesterolemia, hypertension, atherosclerotic cardiovascular disease, myocardial infarction, coronary angioplasty, stent, or coronary artery bypass graft surgery, cerebrovascular disease among women with history of endometriosis. There is an association between endometriosis and autoimmune disease. Although the quality of evidence a little bit poor, but this systematic review and meta-analysis show this association, especially there's an increased risk of association between endometriosis and systemic lupus erythematosus, Sjogren's syndrome, rheumatoid arthritis, celiac disease, multiple sclerosis, inflammatory bowel disease. Regarding malignancy risk and endometriosis, absolute risk of developing ovarian, breast, thyroid cancers in a woman's lifetime were found to be increased in women with history of endometriosis when compared with all women. Colorectal cancer risk was found to be the same in women without endometriosis. Cervical cancer was found to be decreased in women with endometriosis. And endometriosis has been associated with increased risk of depression and anxiety. The symptoms of depression and anxiety in women with endometriosis may be related to endometriosis-associated pelvic pain. However, some studies report that depression and anxiety may predate the diagnosis of endometriosis. Additionally, a genetic predisposition between endometriosis, anxiety, depression, and eating disorders has been postulated. Also, the drugs, especially the GnRH analogs, also has been postulated in the pathogenesis of depression and anxiety among the women with endometriosis. Regarding the treatment, the first-line treatment of endometriosis in postmenopausal patients should be surgical. And one may offer his or her patients hysterectomy and bilateral salpingo-oophorectomy and excision the endometriotic lesions. One should keep in mind the potential increased risk of underlying malignancy in this population. And of course, there is non-surgical options in women during premenopausal period and postmenopausal period. We can use aromatase inhibitors in both state, premenopausal state and postmenopausal state. Evidence is limited to case reports in postmenopausal women. However, the aromatase inhibitors are probably the most appropriate medical treatment for endometriosis-related pain symptoms in postmenopausal women and can be considered as a treatment options when surgery is not feasible, contraindicated, or when surgery was insufficient to resolve the pain problems. However, one should keep in mind aromatase inhibitors may induce hot flashes and bone loss. Especially women in premenopausal state, we can consider to use levonorgestrel IUD system, combined oral contraceptive or progestin, or GnRH agonist and antagonist. MHD considered the most effective therapy for vasomotor symptoms and urogenital atrophy. And indeed, it is effective for both natural and surgical menopause. However, the safety issues are important, and it should be assessed by the risk of recurrence of disease or pain-associated symptoms, and one should keep in mind the incidence of malignancy. For vasomotor symptoms, sleep, and other psychosomatic symptoms, we have to consider to use hormone therapy. And the continuous combined hormone therapy should be preferred, especially in early and premature ovarian insufficiency cases. However, the close follow-up should be done, and especially for the high-risk patients. What is high-risk patients definition? If she had undergone an incomplete surgical excision, or she had peritoneal involvement exceeding 3 centimeters, history of premenopausal endometriosis for long term, previously use of unopposed estrogen, no hysterectomy or subtotal hysterectomy. And we may consider to use non-hormonal options as well for women who are not desired to use the menopausal hormone therapy, and we can use neurokinin 1 or 3 receptor antagonist, SSRIs and SNRIs. If endometriosis-related symptoms recur, so we may consider to discontinue MHD, or we may increase the progestin dosage. If no sequential regimen, if she is on a sequential regimen, we may consider switch to continuous combined MHD or discontinue to estrogen component. And again, we may consider to use aromatase inhibitors. For the GSM symptoms, the first line treatment, we may consider to use the vaginal lubricants and moisturizers. If it fails, so we may consider the topical estrogen, progesterone, topical dihydroepiandrosterone. And although there is not enough evidence, but there are some comparative studies with local estrogen treatment. The laser is promising therapy for vaginal atrophy. For the further information, I will refer our followers, the audience, our EMAS clinical guideline, which was published recent year in 2025. So I also announced our next EMAS Congress, which will be held in Gothenburg, Sweden, in 2027. Thank you for the attention.
Thank you very much, Tamer, for this excellent presentation, especially the very interesting clinical details at the end. I will move on to Professor Kiesel Ludwig for the second talk, and then we can discuss all of your questions. Keep them coming at the Q&A part of your screen. Remember, the chat is only for non-scientific questions, non-scientific issues, potentially to greet each other. So without further ado, Professor Ludwig Kiesel for postmenopausal chronic pelvic pain. Ludwig Kiesel is the chairman of the Department of Gynecology and Obstetrics at the University of Münster in Germany. He studied medicine in Heidelberg, Germany and in London, UK, followed by a research fellowship at NIH in Bethesda, Maryland, USA. He is the president of the German Society of Gynecological Endocrinology and Fertility Disorders, the past president of the German Menopause Society, as well as of the German Endometriosis Research Foundation. He previously served as a board member of the World Endometriosis Society and is currently a board member of the European Menopause and Andropause Society. He has been involved in national and international guidelines on menopause, contraception, endometriosis, and endometrial cancer. His research interests focus on hormonal treatment in menopause and endometriosis, as well as the mechanisms of cell proliferation and invasion in the pathogenesis of endometriosis. He has performed trials in the fields of endometriosis, oncology, menopause, and endocrinology. The main aspect of his clinical work is endoscopic surgery in benign and malignant diseases. And just as a reminder, the topic of this very interesting discussion will be postmenopausal chronic pelvic pain. Ludwig, the screen and the platform is yours. Thank you.
Well, thanks, Eleni, for this wonderful introduction. And I'm very grateful to Professor Erel about his very concise lecture about endometriosis, which already showed to you that one of the main features and one of the main relevant things for patients is actually chronic pelvic pain. But it would be too simple to just pick pelvic pain regarding endometriosis, because there are all kinds of other reasons and you have to differentiate and treat differently patients. So I think this is a very challenging topic, and especially challenging for us gynecologists who are not fully trained in treating pain per se, mainly by surgery or medication, but not in the full detail. So I think this is something very difficult for many of the professions, and patients who are chronically ill, especially pelvic pain and difficult to treat, are usually not so welcome, and many doctors are frustrated. So looking at that, I thought maybe we'll introduce some details about chronic pelvic pain in general, as well as in regard to other diseases, including endometriosis. So I'd like to move forward. So if you have patients with chronic pelvic pain, you are wondering now what kind of clinical presentations are all involved mainly for these women. And of course, we'd like to focus on women in menopause and after menopause. So one of the most important ones is dyspareunia, which has been already mentioned in the previous talk. So the chronic pelvic pain is usually, and this is the second one, this is non-cyclical, pelvic pain, which is different from the usual cyclical pain we know from premenopausal women having endometriosis. Now, of course, chronic pelvic pain involves many different organs. So we are encountering dysuria, dyschezia, and many other problems which can occur in the pelvis. This often actually leads to anxiety and depression in patients because they don't know how to deal with it. And often doctors have problems giving the right medication. And of course, with all this pain, you do have problems with sleep. And so sleep disorder is very common. And also fatigue, which is possibly related to sleep disturbance. And we are all challenged to find out what is actually the cause of chronic pelvic pain in each individual patient. So chronic pelvic pain is generally defined, as I said, as a non-menstrual pain in the pelvic region lasting 6 or more months. And this usually causes neurological changes in the specific area of the spine, which is called the dorsal horn. And this will result in the lower sensory threshold and therefore a greater perception of pain, which means that if the pain is chronic, you already feel at a lower threshold pain, which is a big problem to treat. So pelvic pain is commonly associated with other conditions. As you heard in the previous talk, this includes interstitial cystitis, irritable bowel syndrome, adhesions, and quite a few others. So patients may experience more than one source of pain, which may also radiate to areas such as perineum, thighs, abdomen, lower back. That means that the origin of the pain is not necessarily where it is felt by the patient, and that makes it even more challenging. So therefore, each source of pain must be identified and treated individually if possible. Now, we all know the nervous system from our anatomy and surgery, and we know that, of course, the pain which is transported by the nerves, as shown here, is generally, as we regard it in our specialty, as a local activation of nerve cells, and that is actually a type of pain which is called the nociceptive pain. So that is if let's say a lesion of endometriosis is sitting near a nerve cell and it irritates it, and this will cause, at least in the beginning, a local activation, and that is called nociceptive pain. So that is the original activation of nerve cells, and this is nociceptive. But as soon as we are unable to treat them, then this will be chronic. And then this chronic pain actually changes or alters pain perception, as I said before. So you even feel pain if there is not much pain around. And this one is called nociplastic. And this is very crucial because if patients develop nociplastic pain, it is much more difficult to treat them because patients can even feel pain even if you have removed the actual endometriosis tissue or whatever else. So that's getting very much difficult. So one of my messages is try to treat patients as soon as they have pain rather than wait for years. And as you have heard before, the interval can be a very long time, between 6 to 8 months, years. So that is a long time. Meanwhile, the pain becomes chronic. So that is nociplastic pain. Now, actually, we have a third pain if the nerves are actually damaged by cutting it, etc. So that's neuropathic, but we are not going to talk about now today because this is not related to chronic features. So what happens in the brain? Now, if you have an acute pain, let's call it the nociceptive pain, you see on the top, the brain individual places are activated. Now, this is a functional MRI showing you in individual patients where pain actually is localized in the brain, where it is felt. As soon as this pain starts getting chronic, and after years, it becomes nociplastic pain, this pain perception is altered. And you can actually visualize this in a functional MRI shown here. And you can easily see that even though the same places are activated, it's much more prominent. So those patients with this chronic pain, they feel it much worse, even though the actual reason or location and amount of things causing pain is the same. So alteration of pain perception is shown in the slide, demonstrating to you that this is a serious problem. So we should try to avoid that by acting sooner than after many years of chronic pain. Now, how does pain occur actually? So there are many ways of initiating pain. It's a very important factor in life. And there are many, many ways. Here is shown, for example, in the pelvis, having inflammation by endometriosis. And I think personally that fibrosis after some years can cause very powerful problems, and it can cause pain as well. And this is actually a pain which arises, and this is given as an information to the brain via the spine, which is shown here. So if you don't treat it well, it becomes a nociplastic mechanism, as I showed you before. So this is what we should prevent. So as a lot of research is done, how come in certain patients these things are chronified? And there are now data showing that in this dorsal roots of the spine, there are differences in the development of different modulators, because the pain is first modulated in the spine. And this is different in different patients. And as you will see, it's different in postmenopausal patients than in premenopausal patients, and also in the brain. So you can see that all these factors coming from pelvic organs, also the bowel, also you can see from the bladder here, that all these visceral organs will eventually give some information back to the brain that there is some problems, and this causes pain. So pain, as I've shown you before, this will of course alter the patient's quality of life, which is a bad thing to have. Now, what's happening in patients who have menopause or after menopause? Now, the reduction of estrogen actually causes increased nociception, which means having the same pain in after menopause is felt much worse than in premenopausal women. Now, there are some studies shown that in the dorsal root ganglia, which I've just mentioned to you in the spine, there are estrogen receptors, and these are working differently after menopause. The second thing is that there are also changes of the ion channel, which is important for nerve function, and this increases nociceptor excitability, which means you actually are easier in exciting these nerves with the same amount of endometriosis, for example, in menopausal and postmenopausal women. So that's different before and after menopause. And the third thing is that centrally, the inhibitory signals, which are important to suppress pain, which is not so important, well, this is diminished, which means that you feel even small pain much worse. So in the end, chronic pelvic pain is felt worse in men after menopause than before, on average, not in individual patients, but on average. So chronic pelvic pain is actually common after menopause, but it's not always well regarded. And as I said, estrogen deficiency, which is, of course, after menopause, will affect pain perception. And the bad thing is that early menopause, which occurs in many cases after main surgery for endometriosis, as you've heard before, these patients will have more chronic pelvic pain than women who have natural menopause. And there is even a calculation showing that actually the amount of endometriosis, or the percentage of patients having chronic pelvic pain, is increased 1% every year, which is earlier in menopause in these patients. So there is actually clear-cut data telling us that early menopause is not just bad for other chronic diseases, but it's also bad for having chronic pelvic pain. So all in all, it's the whole picture of endometriosis and pelvic pain and other causes is multifactorial. And due to the problems of diagnosing it, this is, of course, underdiagnosed. So chronic pelvic pain is usually underdiagnosed, mainly for the reasons of having different causes. So, of course, you can see a wide range of other causes, and these are, especially for gynecologists, well-known parts like genitourinary syndrome, as mentioned in the previous talk, which is in more than 50% of women, just as the pelvic floor dysfunction, which is about the same. Of course, there are other reasons and other causes of chronic pelvic pain, and these are often musculoskeletal degeneration, which is very common. If estrogen levels drop, you have a lot of pain and aches in your bones and in your joints, which is a very common factor. And of course, neuroinflammation and central sensitization occurs, which influences other things as well. And this has been shown in the pictures I've shown you about the brain. So there are a lot of psychiatric components involved here, and the comorbidities and comorbidities you have seen before are quite common, at least 20%. And of course, psychosocial factors will be relevant because this involves all your surroundings and your behavior. So this needs to be taken into account. So you have heard before about the endometriosis. I'd like to point out some other causes, and these are the genitourinary syndrome of menopause, which is very common, and women having pain. And if you want to look this up, you can see there is a publication by the 5th International Consultation on Sexual Medicine, which took place 2024, and it has been published by Simon in 2025. And basically, it shows that you can see them as you see it in your practice easily with the different signs in the vagina and the vulva and the urinary changes. And also you can hear it from the patient by the symptoms, which is a wide range of problems of the vagina, the vulva, and the urinary factors. So this is actually something very common, and I'm sure that you know much about it. But all these symptoms actually can cause this dyspareunia and sexual pain. So there can be many different factors being changed, and here those 4 important ones are shown here, which will actually end in this dyspareunia and sexual pain. So what can we do about it? And you've already heard that lubricants and moucheras are the initial things you should do, but there are other things you can add. And the last one is vaginal estrogens, which is very commonly given in Germany, especially with estriol. In some other countries, estradiol. And you can actually have a very good effect in some patients, and some patients need other ones, and you can see here the other possibilities. So let's move on to the second part of the other problems, and these are the pelvic floor pain and also dysfunction. Excuse me. Now you know that you can actually palpate some of the pelvic floor pain by digitally, as it's shown here. And sometimes the cause is there, but sometimes the cause is somewhere else. So this can be actually the end point of that pain, which originates somewhere else. So you can actually examine patients, and it's not rare to find already just by this exam the cause for the pelvic floor for pain. But of course, you've got a long list of other factors which are either independent or actually can influence pelvic floor pain, and in some cases also the dysfunction, just like in pelvic organ prolapse. So when there is some kind of a prolapse, you can have dysfunction, which is bothersome for the patients in most cases, but it can also cause pain. So there are other things, and apart from the gynecological symptoms, you may have also urological symptoms, colorectal symptoms, or other problems. So pelvic floor plane is quite common and dysfunction as well. And it needs to be differentiated. And of course, sometimes several of these symptoms and problems can occur together. So in that means that you need a multimodal management, and you have to possibly ask some of your colleagues in order to help with the differential diagnosis of certain pains. That can be bladder, gastrointestinal, neurological, orthopedic, psychiatric problems. So there's a lot of different other issues which need to be dealt with at the same time. Now, here's a complex slide which actually summarizes how you can go about and how can you manage chronic pelvic pain. So in general, you can have a long list of differential diagnoses. And here are some, and I mentioned just two of them, which are related closely to gynecology. And I think personally that you need a very detailed history taking in order to find out what is the nature of the pain, what is the modality, and what are other factors in the history of the patients. So in the end, you find out what are the topics you could deal with. And in general, it can be a multidisciplinary approach, which may end up for diagnosing surgically, let's say by laparoscopy, or treatment modalities. And this can cover pharmaceutical, psychological, physiological, physiotherapy, etc. We have quite good results with neuromodulation techniques. So you have a wide range of choices in women in menopause, what to do with them. Of course, often patients come back and would like to have some treatment for that pain right away, and then you know about the different medications you can use, and this can go step by step. Initial ones here on the left, and as soon as pain doesn't disappear, and then actually may even got worse, you can go further to step 2 and 3. So there's a long list of treatment modalities with medications you can actually use for these patients. And of course, you should try to leave it once the pain has decreased to some extent. Now, one of my final slides is this complex picture on symptoms of menopause. Because, of course, clinically speaking, chronic pelvic pain is maybe just one aspect in women's health concerns. And you can see here, there are all kinds of other concerns patients may have, and you have to adjust with these treatment modalities. And you have heard in the previous speaker that our society, the EMAS, has actually put together a management, how to deal with patients, especially after endometriosis, either in their history or de novo, and how you can adjust treating those patients with menopausal symptoms. And those of you who would like to do some further reading, EMAS have had several experts on the board who made publications available. And these are clinical guidelines published in Maturitas. And Maturitas, there are 4 topics I've picked here, which you could do for further readings. But of course, we can discuss some of that just afterwards. So thanks very much for listening to that discussion. Thanks.
Thank you very much, Ludwig, for this insightful discussion and for the great information provided. Thanks to both of you, actually. So now we have some time left for Q&A, and I will start going through the questions our audience has provided already. The first 2 were provided during Tamer's talk, so probably related with you, but feel free to express your opinion, both of you, when it comes to providing an answer for our audience. I will just read out the first question. When should we use GnRH agonists and antagonists?
GnRH agonist and antagonist usually we prefer to use in women during the menopausal transition period. And if the other treatment, what I mean, the progestin therapy or combined oral contraceptive or levonorgestrel IUD system fail to improve the pain-associated endometriosis-associated pain symptoms, we may use especially the GnRH antagonist for a while to induce the atrophy in the endometrium. But we have a very limited data about regarding their usage. But we may use, and also the FDA approved this antagonist in endometriosis-associated pain syndrome. I would say that.
Thank you. Ludwig, any experience from Germany which might have not been covered?
Well, I think maybe one has to make it very, very clear that GnRH agonists and antagonists are actually used early in premenopausal women. So today we're talking about postmenopausal care, and there is basically no place for treatment of endometriosis or chronic pelvic pain with GnRH antagonists because that doesn't work. So you have to do something else.
Thank you. Very good practical tip. Moving on to the second question. Is there a non-invasive imaging method to identify endometriotic lesions before surgery?
Unfortunately, unless we have if the woman have endometrioma and ground glassy appearance, it's very difficult to it is very difficult to detect the endometriotic lesions. The history and the pelvic exam comes first, and the endometriosis-associated pain is important in her history and during the pelvic exam. Next, if she has ovarian endometrioma, we may suspect, but especially for the peritoneal implant, we may do further imaging. We need further imaging techniques such as the magnetic resonance imaging technique, and the serum CA 12.5 is useless to in the diagnosis of endometriosis, especially postmenopausal women, because it may increase in heart failure, in some systemic autoimmune disease as well. So we know that there is an association between endometriosis and these disorders. So it is useless. We may consider to look for the human epididymal form, but there is no data regarding the postmenopausal endometriosis. So I would say we need certainty in the diagnosis of endometriosis. Therefore, when we take into account the malignancy probability, so the best way is to choose the laparoscopy or laparoscopy. Surgery is the best diagnostic tool so far.
Thank you very much, Tamer, for this very comprehensive explanation. I move on to another question which seems to have attracted the interest of the audience. The question is, could I ask your preference regarding the choice and dosage of progesterone or progestin for patients with endometriosis?
The dosage is the dosage should be preferred to induce the endometrial atrophy. So we may start the usual dosage, and according to the patient's complaint, so we may adjust the dosage. So, for example, we may use macronized progesterone 100 milligram or 5 to 10 milligram dihydrogesterone, for example, but we may adjust the dosage.
Perfect. Thank you very much. Let's try to get Ludwig's opinion on another medication now. The question is, could you share your opinion about use of tibolone in such women?
In menopausal? Yeah.
In such women.
Yeah, so tibolone is available in some countries, but there is, if you look at the guideline we've been talking about today, you can actually administer tibolone. The only problem is it's mainly has more estrogenic effect. So in some cases, you would like to add some progestin, but there's not enough data to say how safe it is. And this is the main problem of postmenopausal endometriosis on the whole. So tibolone can be administered. I usually decide if it's cases we had minor endometriosis in the history, then I can use tibolone and estrogens alone even. But if you have got marked endometriosis or even severe endometriosis or de novo endometriosis, then you have to have a combined administration. We are talking about postmenopausal treatment, so that's how we should go about it.
Perfect, thank you. Let's continue with Ludwig for the next question. What is the outlook for someone with pelvic venous insufficiency, congestion, diagnosed pre-menopause, when they are postmenopausal?
Well, the entire topic of this venous insufficiency in the pelvic area is a long-standing debate, and usually it's diagnosed by exclusion. So in many women do have some kind of insufficiency. It's most of them don't have any pain. So often, if you don't find a cause, you try to approach the problem. So as a whole, the diagnosis of that problem is very problematic, and it's not easy. But of course, it may change. Usually, it doesn't make sudden change with menopause, for example, and you can approach it either surgically. Medically, it's rather difficult. So it's in cases where you suspect this. I mean, this is usually something you don't approach in postmenopause. So it's a rare situation to have that problem. But of course, if the patient already had that and you suspect it got worse, there is no other way than either do imaging, and you discover if there is a serious insufficiency. That can be a cause, but it's rare. Or you have to do a laparoscopy if you don't find anything else. So in postmenopause, it's a very rare situation, and you have to diagnose it first, which is difficult, and treatment can be done even if you have that surgery, and then you have to occlude the vessels either surgically or non-surgically.
Thank you very much. I will continue with another question on as to whether or not the androgenic estrogen deficiency can cause, caused by gonadotrophin agonists or antagonists, have the same effect on non-receptive pain as that by nature of surgical menopause causing estrogen deficiency. Yeah.
I unfortunately I can't approach the Q&A because I didn't get the whole thing. It was so. Is it that SS the person is it from?
Yes, yeah. The third question.
Oh yeah. Well, now I see what the point is. That so if it's not menopause, but it's a pseudomenopause, which is induced by GnRH agonists, if they have, well, the same thing happens here. So if you have a suppression of estrogen levels, then you may increase your sensitivity to pain. So that can be actually caused in some women to not have sufficient efficiency. But we are talking about premenopausal women, which is not actually the topic today. But if it's pseudo menopause, which is caused by GnRH agonists, you can experience the same thing. The only problem with that is that it's often not given for a very long time. So it is given for a certain period of time. It's not the same as in postmenopause. Well, it's a period of years. Here it's often shorter, so you don't experience it that much. But if your therapy fails, it can be a cause that estrogen deficiency is actually sensitizing to pain.
Thank you very much. One more medical question now. What are the preferred progestins to treat symptoms in perimenopause for women with vasomotor symptoms and endometriosis? And I will try to link this with another person asking which antidepressant is preferred to duloxetine. So which are the ideal progestins and which antidepressant is preferred?
Okay. I will answer. So my preference in progestins, I usually use macronized progesterone and dehydroprogesterone, and also I use the NITA as well in some cases. So you may adjust the dosage. And usually I use continuously estrogen plus progestins, even in women who has undergone to surgery. So I usually follow up with their symptoms, especially pain symptoms. Regarding the question of SSRI, I prefer usually to suppress the vasomotor symptoms, paroxetine or venlafaxine, but you may use the duloxetine or any other SNRI or SSRI.
Thank you very much. I will try to select two more questions. We have some questions left, but we're running out of time. Can you also talk about NK3 inhibitors, which are now emerging as not hormonal treatments?
Neurokinin receptor antagonist. I have unfortunately not enough experience with neurokinin antagonist because in Turkey there is not exist. So I pass this question to Ludwig. Maybe he had experience in Germany.
Yeah, this is a very, very reasonable suggestion because this is a non-hormonal agent, and you can actually try if the main problems are to take care of the vasomotor problems or maybe sleep disorder. There are 2 agents available, and you can use it. There are no studies performed after endometriosis. There are some studies after breast cancer, and you could actually use this data. So you can actually assume the safety is reasonable. And in some cases, there are no other risk factors which go with the use of this antagonist. So from the point of biological effectivity, you can use it. Of course, you don't have the other additional actions of estrogens and progestins. So it is mainly aimed at vasomotor problems and maybe sleep disorders. So all the other factors are not covered as it is done by estrogen and progestins. So you can do it if its VMS is the main issue.
Thank you very much, Ludwig. I have been given the permission for a couple more minutes, so let's see if we can satisfy our audience. Can endometriosis still grow and spread after menopause?
Yes, it may, but it's a very small risk actually. So we have what I recommend is we should closely follow up these patients, especially the patients on MHT, the pain symptoms, during the pelvic examination. We shouldn't omit the pelvic examination, the classic pelvic examination. During the pelvic examination, if she feels any pain, especially the movement of the uterus and the pelvic sides and the portion of Douglas, if she feels any pain, so we may consider to reactivation of endometriotic foci implanted on this area.
Thank you very much. And do you have an opinion, both of you, or experience about testing of urinary marker CYFRA21 in diagnosis of postmenopausal endometriosis and pelvic pain?
I don't even know exactly what marker this is.
Okay.
Okay,
That's fine. That's a pass. And some very interesting comment that came through the chat, but I found it interesting enough in order to discuss it. Considering the complex and diversity of specialties involved, the best clinician to assess the menopause patient with endometriosis will be the gynecology specialist with experience in menopause. Otherwise, another specialist unlikely would want to get involved. So because usually in the UK, it's the GP / the specialist who is getting involved. That is where the question is hinting.
Yes, but this is not true for Germany, for example, where GPs don't care for menopause patients, or let's put it the other way, they don't take care of them because they don't come to them. So we have enough gynecologists who can do this, and the question is also who else. But in Germany, there's not much other choice unless the patients have a direct idea what could be the cause of that problem. So generally speaking, menopause is taken care of by gynecologists in Germany, but that's not true in other countries.
What about Turkey, Tamer?
In Turkey, some general practitioners are dealing with the menopausal symptoms, but especially the gynecologist and subspecialist gynecoendocrinologists are dealing with the menopause. I would say that.
Very nice. And the very last question before we close. So in order to give a message to the audience, does every ovarian endometriosis cyst need to be operated on during the menopause?
Well, this is even unclear before menopause, and after menopause is a little easier because if you have a sudden growth of this cyst, if you have suspicion of intracystic changes, then you have to operate in order to exclude malignancy. So in menopause, the diagnosis of endometriosis is even as it used to be for premenopause, doing it surgically in order to exclude malignancy, which is much more common in menopausal women. And that means in those cases, if you are sure it's nothing else and the patient doesn't have much problems, a small cyst, you don't have to do it automatically with small cysts and asymptomatic.
I would say that if the cyst more than 9 centimeter and long-standing cyst, and if there is a pain and this pain doesn't really is not relieved by the dosage adjustment, so we should be very careful in the long run. So because there may be a malignancy risk. This is the only consideration in my opinion.
Perfect. I think it's time to close the webinar. Thank you very much for the important information on a really complicated topic, and motivated by a comment I just saw on the chat about education provided by EMAS, I would like to close by saying that yes, we're planning much more webinars on very interesting topics on the management of postmenopausal women throughout the year. And we started collaborating with early career investigators, not only from endocrinology, but also European Gynecology and World Association for Obstetrics and Gynecology worldwide. And we're planning the very first 4 societies associated, affiliated, and endorsed webinar in March. And also don't forget the EMAS Academy, which is going to take place in July in Rotterdam, if I'm not wrong. Lovely place. So I hope to see all of you there to continue interesting discussions. Happy New Year once again, and thank you for being here with us.
Thanks so much for moderating us.